everyone, and welcome to the Texas Epidemic Public Health Institute and the P2OR Consortium's Infection Prevention 306 High-Level Disinfection. We will be briefly introducing what high-level disinfection is in healthcare practices today. If you're new here, all the material is recorded, and within about a week, you will get a link with the recording and the slide deck today. We ask for all questions to be held until the end, where we'll open up for some Q&A. You're able to unmute your microphones, or if you feel more comfortable, putting your questions in the chat. So again, the lectures are recorded. You will receive an email about a week after today's presentation with the lecture and the recording, and I ask for all questions to remain until the end. So I am your speaker today in your presentation, your presenter of this series. My name is Dr. Kayla Rush, and I am a seasoned infection preventionist, and I have my PhD in epidemiology with my master's in environmental and occupational health. I am certified in infection control, public health, and healthcare accreditation as well. And here's just a brief overview of myself. And I work at TEPI, which is the Texas Epidemic Public Health Institute, which is housed in UT Health Houston School of Public Health in Houston, Texas. And the goal of TEPI is to really create a more robust Texas community by providing education, training, to really strengthen our Texas communities to respond to the next future infectious disease outbreak. So today's lecture has been approved for continuing education credits through the Texas Health Department Public Health. So here are just some disclosures on today's series. To be eligible to complete and obtain your education credits, you will have to attend the activity, complete the post-test and the learning activity, and obtain an 80% or higher. Today's lecture has been approved for CMEs, CNEs, so our medical education, our nursing education, along with our certified health education specialists, our public health certified professionals, and registered sanitarians. It's also been approved for 1 hour of continuing education from the Board of Infection Control for ICIC or APIC holders. So this lecture will have no commercial support. I am a consultant for BD, but this lecture will not have any of their products or promotion of any of their devices. Okay, so let's get into today's learning objectives. So our main learning objectives for this lecture is to really define and describe the foundations of high-level disinfection. And then we will talk about the process for specific equipment, and then we will discuss monitoring our high-level disinfection practices, equipment, and making sure that we are survey ready. So high-level disinfection. So before we begin, I want to briefly talk about the Spalding classification framework. And this was created back in the 1960s from Dr. Spalding that puts a hierarchy of how certain equipment in healthcare facilities need to be cleaned. And the hierarchy goes at non-critical items, which are items or medical instruments that come into encounter intact skin, require disinfecting or cleaning. So that's our low-level type of equipment, and that equipment usually is our stethoscopes, our blood pressure cuffs, anything that is coming kind of in contact with our external body. So anything on our skin that we're using. Our next tier is our semi-critical items, which require high-level disinfection. We'll be focusing on those items and process through this lecture today. And those are reusable ices that come into contact with our mucosal membranes, our non-intact skin. And then lastly, we have our critical items, which require sterilizations, and that's really in our sterile tissues and body cavities. Next lecture in August, we'll be talking about sterilization and what that looks like in the process and different chemicals that are used, but today we will be focusing on high-level disinfection. So as I mentioned, high-level disinfection is the process of destroying all microorganisms except for a level of bacterial spores. Sterilization, which we'll talk about next month, eliminates all organisms and bacterial spores. So sterilization gets rid of everything. High-level disinfection gets rid of most things, but some bacterial spores. High-level disinfection, or HLD, as you'll see in the rest of the lecture be referenced as, it is required for semi-critical items that we said, which are items that come into contact with our mucosal membrane or non-intact skin. And this is just a list of some of the common items that we see. A lot of our endoscopes, bronchoscopes, our other probes, our catheters, some of our probes, our prostate, and also our vaginal probes as well too, are kind of the more common ones that we usually see, and that there is a way of auditing and monitoring. So these are just some of the frequently used items, but definitely check at your facility what type of items you're using. And then see what type of either cleaning, high-level disinfection, or sterilization practices need to be followed for those pieces of equipment. So high-level disinfection, as I mentioned, this is kind of a nice little graph or chart that kind of breaks it down, is that it destroys all organisms except for a level of bacterial spores. The two main methods that are used in high-level disinfection is heat automation and liquid immersion. And depending on your type of equipment and what the manufacturer for use, or MIFU, says, you'll be using different methods to make sure that you're processing it with a certain time, temperature for that certain cycle for that specific piece of equipment. And these devices that usually have high-level disinfection, they're very sensitive to heat. So that's why they can't be sterilized. So that's another thing to make sure that these items never go through sterilization, that they're specifically for high-level disinfection processes. Some common disinfectants that we use in this process are, you can see here, our OPAs, our hydrogen peroxide. I want you to pay attention that bleach is not one of these chemicals. So if you're auditing or monitoring something and you're looking at the device and it says high-level disinfection, that does not mean cleaning it with bleach properly disinfects all the material. So it needs to be a specific chemical. Some common ones are listed here, and then the chemicals with the certain time and temperature variation is dependent on that piece of equipment and that chemical composition. So different chemicals will have different times. So it's not a one size fits all type of thing. And then based on your piece of equipment as well, that you'll use different temperatures of disinfection and times for those cycles. And what's really the main importance of making sure that we conduct high-level disinfection is that it ensures a culture of safety. It really prevents HAIs. It maintains device function and longevity. If you're cleaning a device properly, you're going to get a longer use of it. There's not going to be as much breakdowns, cracking in it, compared to if you are not cleaning it or disinfecting it appropriately for the time, temperature, and duration. You can lead to cracking your certain scope or your piece of equipment. You can have breakdown of it, or you can have improper cleaning, which then we will have certain biofilms on that specific device, and then that's kind of a breeding ground for bacteria, and then MDRO bacteria specifically. So we want to make sure that we are specifically cleaning these types of equipment appropriately according to the manufacturer instruction for use, or the IFUs, because there can be big consequences if there is improper cleaning. So that was just a basic overview of what high-level disinfection is. And now we're going to go talking about a couple pieces of equipment, and then we'll go into monitoring afterwards. As you've heard me mention before, the first primary thing with any device of determining what Spalding classification it needs, if it's needs cleaning, high-level disinfection or sterilization, that will always be listed in the manufacturer instruction for use, or the MIFU. That is the specific document of how that device should be handled, stored, cleaned, processed, pre-cleaning, cycle times of cleaning, when and how it should be used, everything. It will specifically tell you in details how to handle that piece of equipment. And before you start either monitoring, or if you are looking at creating, if you're sitting in your purchasing committee and you're looking at new types of equipment, you always want to request the MIFU before purchasing. Make sure you get it, you look at it, and you're looking to see what type of instructions that IFU has, if that is something similar to the equipment that you've used. Do you have the capacity to do what is needed, aka you are set up for the cleaning and storaging of that piece of equipment? What type of training staff need to handle that device, to clean it, store it, transport it, etc. And then also, is that something similar to your other policies for your other devices that you have within the organization? You also want to document like any type of communication with the manufacturers. When you're sitting on the purchasing board and you're looking at a new piece of equipment, you can always reach out to the manufacturer and ask for the MIFU. And then once you obtain it, if you have questions, they should be able to answer it. If they don't, I would shy away from buying that piece of equipment, because it's going to cause you more problems in the long run if there is ambiguity or not clear instructions of how to handle it and process it. That leads you open to a citation later when you are going through your CMS Joint Commission audit. And it kind of also, with if it's not clear on how to clean it, it also could open you up to having HAIs and other type of transmission spread, because you don't know how to properly clean, high-level disinfect, or sterilize that piece of equipment. So always make sure you have that documented in written communications with the manufacturer if you have any questions about it. Asking for other studies or white papers they have on the device along with the manufacturing IFU. And why this is important is that first, it ensures patient safety. It really prevents infections from improperly being processed device. So if you are following the instructions that have been vetted through all the regulatory agencies, CMS, TJC, FDA, and OSHA, you should not have any patient harm from that device if the proper instructions, handling, and storage of that device is obtained. And that really also supports the device performance. If you are cleaning it as instructed and there's chemical residue on it, or there's breakdown of the piece of equipment, that's something then you need to take back to the manufacturer of saying, we have the IFU, we have been cleaning, high-level disinfecting, or sterilizing the piece of equipment according to your instructions. However, we are still seeing these breakdowns. What's going on. That's another type of communication you will have with them. And then also, as I mentioned before, it prevents citation. So knowing exactly what the hierarchy is and following it appropriately, that will prevent you from causing harm to patients. And here's just kind of a nice graphic on the hierarchy of compliance. You always want your federal regulations. That's always your top tier of what is required, how you should be handling that device, and then your CMS conditions, what they say, how you should handle, restore that. And then it goes into the manufacturer's IFUs, and then evidence-based guidelines, and then lastly your facility policy. And your facility policy should be based on the federal regulations to make sure that you're not getting cited, or also it reference your specific policies, the IFUs. In your policy, if you're changing vendors if you're going from one vendor to another vendor, make sure that in your policy you say, it's clean and handled and trained according to the IFUs within your policy. You don't need to get into the very detailed specific within your policy in case you are changing vendors later. Or if you get a new piece of equipment from a different company, and you won't have to rewrite your policy because you said, using the company's A guidelines, blah, 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 but you have company B's device, you're just leaving it up as according to the IFUs of that specific piece of equipment. However, sometimes with our IFUs, there are challenges with looking at them. If you're new to looking at them or describing them or requesting them, sometimes the language can be very ambiguous or missing instructions. So that's what's important when you are first looking at a device. If it's not clear what you should be doing with it, make sure then you're reaching out to the manufacturer to ask that clarifying questions, and you get that within written documentation that you can include as well. Sometimes there is conflicts between device and accessories. So the main device says it's clean, high-level disinfect or sterilize A, B, C, or D, but then the accessory says a different level of, for example, let me rewind. For example, the device has to be high-level disinfected, but an accessory or a piece of adapting that you're on for such as like a biopsy or another additional piece, says you only have to clean it. Well, that doesn't make sense because that's a lower level of cleaning / disinfection than the main device than that. So you want to make sure that you know what's adding onto the device and that it's all at the same level or a higher level. Sometimes they are unavailable. So when you're purchasing, making sure that you're looking at the IFUs or requesting them, and making sure you're not going forward without them. And then the last thing is lacking with compatibility within your facility. So making sure that when you're getting a new device, that if there are certain steps that you have to do, that you have a designated specific sink or a certain type of cabinet. Do you have that cabinet, or is that a new cabinet you're going to have to be buying to house that piece of equipment? And is that within the budget? Do you have space for it? What does that look like? So making sure that the piece of equipment that you have, that you are set up to actually use it within your specific facility. And Shea and APIC came out with a great guideline reference, which the DOI is here to really talk about when there are challenges, what do you do and how do you go through that hierarchy of this is unclear, what does this mean? It's a great reference. It came out, I want to say earlier, end of March, April. If you haven't read it, it's in their Itchy magazine, their journal. It's a great tool to look at. So the link's here for that. The next thing I'm going to do is talk about one of our very problematic pieces of equipment is our endoscopes. Our endoscopes have specifically been linked to more HAIs than really any other device, reusable device in our facility. And that's because they go into our mucous membranes. A lot of these scopes are either in our upper respiratory tract or our GI tract, where a lot of bacteria are housed in that area. Biofilm can be present in those areas. And it causes for a lot of outbreaks, especially when they're not cleaned and processed appropriately. There's also many components that usually when we're doing scopes that looks into it that, we're improperly reprocessing devices, and we'll talk more about that later when we talk about monitoring. You can have multi-dose vials, or since they're doing a lot of scopes of looking at anesthesia equipment, also from poorly processed bronchoscopes, and then also contamination water, and then our uteroscopes as well. So a lot of types of outbreaks have led to improper high-level disinfection of these scopes within healthcare facilities. And it's a wide range of bacteria that is present on it, and it's leading more towards the recent outbreaks of MDRO bacteria. So we want to be very cautious to making sure that high-level disinfection is being done appropriately and according to the MIFUs for the device. And why this is so challenging, if you're new or not sure what an endoscope is, it has multiple channels. So the first thing is that it has intricate design channels. So it has multiple lumens, and it can have a single lumen or multiple lumens, which you see here in the picture, which is this narrow device that you can obtain a biopsy through. So it's really hard to see if it's clean. There's no direct visualization to see if that channel has been clean. And they are heat sensitive material, as I mentioned earlier, so they cannot go through sterilization. They have to go through high-level disinfection, which can, some of the HDL can be resistant towards certain organisms. So you want to make sure that if you're working with a really resistant organism, that you are looking at how to process that and to see what additional steps you need to take. Not only just one round of high-level disinfection, maybe it's a couple rounds, but you want to be talking with identifying these patients, knowing what equipment is being used on them, and then also talking to the manufacturing if they have recommendations, if you're using a certain pathogen with this organism, with this piece of equipment, that if there's a special way of processing. And then, as I mentioned, the biofilm risk. So due to the multiple channels and not having direct visualization, they are dark, warm channels, which they can have residual moisture, which we know warm, dark, moist items are breeding grounds for bacteria. They love to grow in them, and that can shield them with the development of the biofilm from disinfectant and increase infection risk for these certain devices. Another thing with them is that they can also undergo microscopic damage. Sometimes with these scopes, the tips can get bent, it can get broken, it can get cracked. And it's really hard to see, so you might not know that it's defected. Also, with the inside of the internal lumen, you might not know that it's cracked in there because you don't have direct visualization, as I mentioned. So making sure that you're examining this and you're really looking at care, and staff that is processing these devices is really working diligently and inspecting these every step of the way. There's also workflow breakdowns. There's always a shortage of SPD individuals or people in sterile processing. There's always a shortage of those individuals with specific training. So making sure that the people that are there, they are trained well, they know how to handle these devices, they're comfortable following the instructions for use. And then lastly, sometimes at your organization and other organizations, there's poor traceability. So making sure that you have a hardwired system of knowing what cycle that this specific scope was processed in, and when it needs to be reprocessed, and who handled it, and what patient it is, that needs to all be laid out so we know in case something happens, or if there is an outbreak investigation and saying that, the high-level disinfection AUR failed on scope A, we can look back and see, well, when was scope A processed? Who used scoped A, and what does that look like? So you can quickly identify if something happens, what type of logs and the people that have been exposed to. So, and then here's just depending on your facility, you can either manually perform high-level disinfection, or you can perform it with your AER, which I believe more organizations have gone to. Kind of eliminates the human error of it, and it also is a little bit safer since we're reducing chemical exposure to our staff members. But we always have our pre-cleaning, which is done manually. The AUR doesn't do that, so we need to do that before. And then next, our leak test. Depending on your system and what AUR device that you have, sometimes that is included in it. Sometimes you have to do it before. So make sure that you know what your system at your facility looks like, and if that's included in the AUR, or if you need to do that before. If there is manual cleaning involved, rinsing, post cleaning, if what is being done And then looking at your drawing, some models do it, some don't. And then also where you're storing this. The storage is never just in the AER. There needs to be going into positive pressure drying cabinets. So making sure that you have that at your facility. Okay, so now we're going to go into monitoring of just how we can monitor our high-level disinfection process. So just like any good IP in our high critical areas, they should be audited constantly. And we want to make sure that you are auditing any type of area that has high-level disinfection for that equipment. So knowing where your equipment is and what units are using them, you want to definitely go to those units and see how they are handling the device, how they are processing, how are they transporting, is it just sitting there, is it being handled appropriately. And some of the main units where these scopes are used, especially either your endoscopes or bronchoscopes, they're in endosuites, imaging, ultrasound, your cardiac cath for your TE, pulmonary unit, and your operating use. And they can be in other units too. Maybe they're in your ED for emergency scoping. Who knows? It's always interesting to go around to different facilities and see where their pieces of equipment are. And during when IPs are monitoring, you should trace the device from procedure to storage in the clean room. So going through the whole process, and the main four components of that is doing the point of care cleaning, transporting to the area where that you're going to conduct high-level disinfection. High-level disinfection on the equipment is done, and then you're verifying those processes and that it's being stored in an appropriate location. So here's just another breakdown of how the steps are. So you'll be at the procedure, you'll look at point of care, you'll look at how the equipment is placed in the bin, and going through all the steps, and we'll talk about these in detail. So this is kind of just the roadmap that we're going to talk about. So the first step is discussing a time to observe procedural staff. So before you come in and audit, it's always great, especially if you are new, a newer IP, or if there is newer leadership within the high-level disinfection space. You always want to make sure you have a time to set up and come in and audit. So be mindful of their schedules, of what works for them, making sure that it is a scheduled procedure versus emergent procedure. It's also great to look at emergent procedures of how things are done appropriately. But also, you know, there's an emergent procedure, there can be more people in the room, there could be, so you want to be mindful of that too. Also discuss complications during the procedure, and the big thing is to be on time and make sure that you are ready to go, especially that these suites where the scoping should be done are under specific pressure. You don't want to be coming in and out during time of procedure, so make sure you're on time, and or if not, early, to make sure that you're set up. And before you go and look at the procedure, ask for the manufacturer instruction for you. So ask for that MIFU before you go in and observe that, so that you can ask questions, you know what you're looking for. If something's not clear for you, you can ask the tech while auditing them of why they are doing something a certain way. What does it mean in their IFU? And sometimes bring a copy, print out a couple pages. Sometimes they're huge documents, but bring out the most important pages with you so that you can reference it. It's a good way for them to practice speaking to it. It's better a friendly face of you, the in-house IP, versus than an auditor, someone with CMS really critiquing them. And pointing out negative things, which can lead to a citation, compared to consistently auditing them of finding mistakes before it causes a problem. So definitely review the manual, make sure you look up the procedure that they're performing so they know, you know what's going on, and then what PPE is needed for yourself, and also what is needed for the staff members too. And if you are new to the auditing high-level disinfection, ask to see if you can audit a more senior level tech, or when you're scheduling an appointment with your high level disinfection team, specifically in the suites and the endo suites and the bronx suites, to see if you can go for more seasoned individuals. They'll be better to speak on the process. You want to make sure you're making everyone comfortable. And it just helps to foster a collaborative learning experience for both people. Okay, so the next is going to be the point of care, cleaning, and removal. So at the bedside, we've gone through the first phase, we've scheduled a time, now we're there, we have observed the procedure, and now the procedures end. So the first step is to look at, you're in the room, the procedure is done, you're on your PPE. We want to observe how the point of care cleaning is done. So you want to be able to see them wipe down the piece of equipment with a lint-free cloth and remove all visible or gross material from the piece of equipment. So while you're doing this, monitor and ask about the material of the cloth to wipe down. It should be lint-free. They should be able to speak to that it's lint-free. And then you're also watching them visually inspect the equipment. So they're looking at the piece of equipment, you're looking at the piece of equipment. And then you can always ask if they know if they're aware of any of the material trapped in the lumen. How is that communicated? Is there any concerns? Did the device, work appropriately? All of that time, you can be asking those questions in this phase. Next, you will then, after they wipe down the piece of equipment, they should place it in a puncture and leak-proof resistant container, and it should have a biohazard symbol on it. So here's just a picture of some common containers. The containers might be different based on your facility. Another great question to ask is, how do you know if the container is dirty or clean? Sometimes the transport containers are the same. So definitely ask the question of, is it clean or dirty? Sometimes it's designated with a certain lid or a certain bin. Red is dirty, green is clean. So that's another thing that you can ask. So during this phase, you want to check that all equipment fits in the container securely with a closed lid, and they should not be shoving the piece of equipment in the container. It should nicely fit in there. If they're shoving it and bending it, that's more likely to cause one of those microscopic damages that we were talking about before. So also talking about that with the staff, of making sure that they're handling it appropriate, that the container closes, and that it fits appropriately. Before they close the lid, so they put the piece of equipment in the container, they should be spraying it down with an enzymatic spray. And this should remain wet until it gets into the area where they're conducting a high-level disinfection. And the reason why it needs to remain wet is that this prevents biofilm forming. So definitely ask about the expiration dates on the spray. Ask when they open it, when does it expire. Ask to look at the label and the IFU, making sure that it's compatible with the specific device that they're using it, and the duration of the spray effectiveness. So some sprays are good for 24 hours, some are good for 72 hours. So we want to make sure that we know what the duration of the spray is, especially for those weekend, such that you're having a device used on a Friday, it's not going to get reprocessed until Monday. That enzymatic spray should cover and remain wet until Monday, when it is up for reprocessing, or for processing, to really prevent that biofilm formation. So definitely look at all of those things when you're in this space. Next, you will then go with the device to the specific area where high-level disinfection will be performed. This could be in the same room, it could be in another room, it could be all the way in a different area of the hospital. So definitely make sure you walk the path and see what kind of obstacles are within the path. Is there also communication of that, hey, where the dirty device is leaving, now it's going to the high-level disinfection area space? Is this area staffed all the time, so it there's someone there to receive it, or is this an area where the staff is in a different, maybe they're working in the sterilization and they need to come over and do a high-level disinfection, making sure that you know the communication process, how do they know that there's device ready for processing? Is there a certain log? Talk about those things, about how this is being communicated within the team and within the organization, of that this device is going from one department to another, and is the communication timely and effective. Next, then you will start observing the high-level disinfection process. So we'll be looking at the pre-cleaning, the leak test, and kind of getting it ready if it's manually cleaning or if it's getting put in that AER, which you can see this is just one device. The devices look very different. Your facility might have one, you might have a ton of them. So making sure that you are observing how they're pre-cleaning it, how they're transporting it, what PPE is the staff wearing, are they changing PPE, is there designated dirty and clean zones within the suite? There should be a dirty sink and a clean sink, and how is that designated? If they're doing pre-cleaning, according to the instructions for use, what type of dilution are they using? How do they test their dilution? When were their chemicals open? When do they expire? How do we know that the dilution's correct? Especially if it's one of those devices that is an automatic dilution that it calculates. I know Ecolab and some other companies have automatic dilution sets. Making sure that they are in serviced appropriately, they're checked. How do they check it? How often do they check it? And then making sure all the chemical labels you're looking at, making sure that they haven't expired, they're good to use, and that they're okay to use within that specific device. And then ask about the times. How do you look at the printout of the device? The load time, that if it was successful, if it failed, if it has internal controls or external controls, what does that look like? How are they done every cycle? Are they done every day? Are they done multiple times a day? Making sure that you know your process inside and out. So making sure that you have those questions, and then where's this being logged at? That's another thing that you want to make sure you're monitoring. So not only the process, but then you're looking at the logbooks as well, because that is something that the surveyors will want to look at. How do you know that this passed QC or quality control? How do you know this was effective duration and cycle temp? Is that an electronic printout? Does it get uploaded into a digital drive? What is your process in your facility? So definitely talk with your staff, especially when you're monitoring and auditing them, that how is this being documented, so that there's not potential gaps later. And then also, are these devices have a serial number, and as that being a type? So how do you know that scope A is located or relates to cycle A? How is that? Is it written in with a certain number with their serial device? Is it given a number? How is that? Is there barcodes on these devices that are scanned that your system? How do we know that? So not only is it being done, but then how do you trace scope A with cycle A, and that it's been passed, and that you have proof that it's been passed? So the next part is removing it from the container. So after it's being done through the high-level disinfection process and going through the AER, you want to see how staff are removing the device and then hanging it in the certain cabinet. We want to make sure that we're changing PPE. You want to look at workflow zones, so they're not coming from a dirty zone and dirty PPE over into a clean zone with dirty PPE and then hanging it. And then, as I kind of mentioned in our last slide, definitely looking at the logs. Where are they? How is it documented? Looking at your time, pressure, quality control, all of those things need to be written down as well. And then lastly, you want to watch your staff member take that scope over to your hanging cabinets. They should be positive pressure. And then you want to look at how are they hanging them. So you can see here on some of the pictures, they need to be hung independently and not touching them. As you see here with the two red circles, the ends of the scopes are touching and they're crossing over, which isn't great. So they've been potentially contaminated. So you want to make sure that you're checking dates of the cabinet inspection. When was the cabinet last inspected? Is it maintaining the proper air pressure? When was the cabinet last cleaned? So yes, these are clean cabinets, but our clean equipment also needs to be cleaned appropriately. So making sure that they're cleaned at a certain cycle or schedule time based on your workflow, and then any logs or tags. So another thing that comes in with scopes of processing that Amy and OSHA really recommend reprocessing scopes in 7 days if they have not been used. So if you have a scope hanging and it has not been used in 7 days, it needs to be reprocessed, which means it needs to be reran through high-level disinfection and then hung up. So you should also have logs or tags to indicate when was the last date of reprocessing for that specific scope and when is the date of the reprocessing. So that tag should say when it was processed and when it needs to be reprocessed. And then how do you log that and track that within that device too. So making sure that you just have from start to finish, you know your process, you know the steps, and then you're monitoring them, because that will come into great effect and ease when something does go wrong. So if something does go wrong with your scopes, the first step is to really confirm there has been a failure, so that you have confirmation that either a cycle or one cycle with one device or that whole system has failed in something. So you want to make sure that you have confirmation of the failure. Next, you want to obtain any improper high-level disinfection cleaning items. So if you know that your AER failed, you want to make sure go to your logbooks and see what scopes were processed on that day and then obtain them. Take them out of service until you know what the next step is. And then the next thing is then to communicate. Make sure that you're communicating that there has been a failure. Do not use this piece of equipment until it has been either in service, sent out to the vendor's coming out to process it. And then the next step is then to inform key stakeholders, AKA your C-suite, your director of infection control, maybe risk as well, to see that, hey, there's been a failure. We're looking at how many devices has not been cleaned appropriately, and then how many of these devices have been used on patients not high-level disinfected to clean appropriately. So then the next step is looking at the evaluation of the equipment of failure. So getting your vendor out of telling you what happened, why it happened, what is going to be done to prevent future failures. And then you want to start creating a line list of procedures and equipment that were exposed. So who potentially is at risk and who was used an improperly high-level disinfected scope on a patient. So making sure those logbooks that I talked about earlier, we have a high traceability with them. This will make creating this line list a lot easier and quicker if you already have that. And then assess what has gone on, what the level of risk is, based on the patients being used and the system failure that has been developed. And then you want to inform, expand your notification to your staff, make sure that the whole department staff for that specific device know, and then discuss the next thing is discuss and hypothesize what was the failure, what are we doing about it, and what can we do to prevent it from happening again. And then we will develop a method of tracking these adverse event and identification notification. So you want to then, we have our line list of patients that have been potentially exposed. Now we need to have a tracking system of how we're potentially going to notify them and how we're going to track that and what our next steps are going to be doing. And at that time, kind of the adverse events, notification and patient notification is kind of all happening simultaneously. So after you know the extent of the problem, then you're discussing with C-suite and if state and local federal authorities, if notification needs to happen, if a device needs to be recalled, what's the extent of the problem, and then discussing how you're doing patient notification and what you're offering them. If you're doing prophylaxis or exposure therapy, what kind of things and treatments do you need to provide them? So that's making sure that you talk with your risk team or legal and quality of what the next steps are. And then following that, you'll develop and implement long-term follow-up to prevent future failures to make sure that this doesn't happen again. And then lastly, after the whole cycle is completed, doing a debrief and doing a SWOT, your strengths, weaknesses, opportunities, and threats. So I know that was a lot of information. So now we're going to go into a quick knowledge check, which is a 10-question learning activity to see what education you've gained from this lecture, and then we will open it up for questions after that. So I invite you all to scan the QR code. You can unmute yourselves, or if you feel more comfortable, you can put the correct answer in the chat. So I'll give you just one more minute to scan the QR code. All right. So question 1. What is the purpose of high-level disinfection? Is it A, B, C, or D? Removing visible soil from equipment, killing all bacterial life, including spores, destroying all organisms except for bacterial spores, or preparing items for sterilization? Excellent. Yes, the correct answer is C. Question 2. High-level disinfection requires what category of Spalding classification? Is it A, critical items, B, non-critical items, C, semi-critical items, or D, disposable items? Great. Yes, the correct answer is C, semi-critical items. Question 3. Which of these are a common chemical used for high-level disinfection? Is it A, bleach, B, isopropyl alcohol, C, OPA, or D, ethylene oxide? Great, yes, it's C, OPA. Question 4. Why is it important to spray enzymatic cleaner before transportation? Is it A, to label it as biohazard, B, to ensure mechanical functionality, C, to prevent biofilm formation, or D, to dry the equipment? Excellent. Yes, it is C, to prevent biofilm formation. You guys are doing great. Question 5. What is the primary risk associated when endoscopes are not properly reprocessed? Is it A, radiation exposure, B, infection from resistant organisms, C, device overheating, or D, physical damage? Excellent. It's B, infection for resistant organisms. Question C. According to the hierarchy of compliance, what should be evaluated before a new device is purchased? Is it A, cost of accessories, B, manufacturing structure for use, C, facility size, D, competitive pricing? Excellent. Yes, it's B. As I mentioned before, obtaining and reviewing and looking at the MIFU is critical for any piece of equipment in healthcare, regardless if it's high-level disinfection, sterilization, or even just cleaning. It's very important. Question 7. Which regulatory requires compliance with the MIFU? Is it the FDA, OSHA, CMS, or D, all the above? Excellent. It's D, all of the above. Question 8. What is a common challenge in high-level disinfection of endoscopes? A, compatibility with sterilizers, B, poor visual of internal pathways, C, lack of electricity, or D, frequent single use. Excellent, yes. B, as I mentioned, poor visibility of internal pathways. That can lead to a lot of problems, especially when we talked about biofilm formation. Question 9, what is the appropriate action when monitoring bedside pre-cleaning of a device? A, ensure the lid is closed immediately. B, confirm enzymatic spray was not used. C, check for visible soil removed and proper wipe down. D, skip the check if the equipment is urgent. Excellent, yes, C, check the visible soil is removed. And the last question is, what is one essential element of high-level disinfection monitoring in a facility? So ensuring the device is only used. B, verifying logs, indicators, and visualization. C, washing the device manually only. Or D, using only FDA cleared disinfectants regarding menu. Excellent. Yes, it is B, making sure, as I've spent the last 10 minutes verifying logs, indicators, and then doing a final visual, especially when they're in the drying cabinets, making sure that they're not touching the ground, not touching each other, not touching the side of those cabinets. That is really, really crucial. So here are the correct answers. And as we've talked about, just kind of wrapping up this lecture, high-level disinfection prevents HAIs by making sure that our equipment is properly cleaned, processed, stored, and reprocessed according to the IFUs, making sure that our staff are safe during reprocessing and processing through proper cleaning, processing and reprocessing and storing of the equipment, and compliance with the MIFUs and AAMI standards are maintained to really help us with survey readiness and create a safe environment and provide excellent care to our patients and reduce harm from improper high-level disinfection, cleaning of certain devices. So we invite you to connect with us. Here is our email if you have any specific questions, along with a QR code with going on to the TEFI site to find out what other types of TEFI cores are available. Our next lecture, as I mentioned today, will be on sterilization, and it will be on August 7th. And we'll talk about sterilization, describe the process, and discuss monitoring. I ask that everyone completes the post-module evaluation after today by clicking the QR code. We really appreciate your feedback on this. This really helps us know what to talk about, how we're doing, what type of content that you would like to see in the future. Also this week, some of you might have received a email asking you to complete another survey for our mid-series lecture as well, to give feedback. Please complete that. If you have questions, please reach out to that IPC at tefi.edu email. And then also the TEFI series publications on our TEFI pilot lecture 100, our 2023 lectures, and last year's lectures from our 200 series that was done in 24 was just published yesterday. So here are the links to those articles. As I mentioned before, the lecture and the slides will be available within about a week from today's lecture. It might be a little bit longer due to the holiday. So within a week or so, you should get a link to the lecture in the slide deck. And then also this is the instructions how you can obtain your continuing education hours, as I mentioned at the beginning of the lecture. And now I want to open it up for any questions anyone has. So feel free to unmute yourself. So the previous, if you go on the TEFI YouTube channel on the recordings are linked on the Tefi. If you type in your Google search Tefi IPC YouTube, you should be able to look. Oh, thank you. Look at the previous recordings and the slide decks. And if you're having trouble finding one specifically, please email me and reach out. I'm more than happy to send you some links as well.
Hey, Kayla, I have a question. This is a great presentation. I have a question about transport spray. I have a leader in one of my facilities who's very familiar with the AAMI standards, which is great, but she interprets the phrase remove gross soil at point of use to mean that the instruments need to actually be wiped down and soaked in enzymatic before spraying with the transport spray. So she's directing staff to really handle those instruments, which we would prefer be done in decontam.
Yeah.
Anything you can say to support that removing gross soil is done by that wipe down and spray with the enzymatic?
That's a great question. Thank you for asking it. I would maybe reach out to is it all devices that she's doing this with, or is it just a specific device?
Specifically dermatology instruments.
Okay, I would definitely first, what you could do is pull the MIFUs and look at the clarifying language of how it's being processed. And then second of all, maybe meet with your leaders of decontam, and this individual as well to talk about throughput, because that seems like it would cause more time of devices sitting up there than getting down where they're supposed to be. Also, I'm just thinking maybe device over soaking, and just turn over a room. It's not needed. I would also maybe look at maybe pulling some of the other AAMI standards to her as well, to say that it doesn't require a pre-soak. It just means moving, like with a lint-free cloth, it's just removing the visible. And maybe just highlight that it's visible. It's not, everything that's soaked should really happen in decontam, to make sure that, we're doing it correctly, and that you're not over soaking an item, and making sure like the dilution is correct that she's using, and that the chemicals that she's soaking it with too, if it's just the spray, that it's compatible, but also, that's kind of improper use of the spray. So you could talk about the financial component of, if you're going through so much enzymatic spray, what the financial cost is that, and there's not really a benefit to. I would maybe frame it a couple different ways.
That's wonderful. Thank you so much. This is a great presentation.
You're welcome. Any other questions? Let me go. One of the questions is the proper storage of the endoscopes again. So endoscopes should be put into positive pressure cabinets. I can go back. Go back. Okay. Endoscopes should be what you see here on this slide for placing in your drying cabinets. They should be in a temperature and pressure controlled cabinet. They should be hung independently. So that means that they shouldn't be touching the back of the cabinet, the side of the cabinet, each other's scopes, and the bottom. So they should be freely hanging. And most of the time in these newer cabinets, there are specific valves that you can put in the channels that constantly circulates air through it to really help reduce that bioburden. So another thing you want to look at is that every specific endoscope has specific cabinets that goes with it. Usually, whatever organization or manufacturer that you're getting it, they kind of put them together. So definitely look at what type of cabinets and how big your cabinets are based on your scopes. Your endoscopes or your duodenum scopes, there can be longer or shorter if you have ped scopes. So making sure you have enough space where they're not touching each other is really, really important, and that they're being cleaned and serviced appropriately as well. Did that answer your question? Okay, great. And then the last question is thoughts on TEE probes requiring reprocessing. I would check the AMI standards on that. I know 7 days is kind of the standard we use. It's kind of nice to keep them on the same cycle. But definitely look at your specific device of what the manufacturer recommends to see if it needs to be changed for that. So that's what I would recommend with that. And then making sure that's documented as well and that you have good tags and a good system within your cycle to make sure that it's being identified, looking, and then reprocessing accordingly. Any other questions? No? Okay. Well, thank you all for joining us today for the lecture. I hope you all have a safe holiday weekend, and I look forward to joining next month at our sterilization lecture. And please reach out if you have any questions. More than happy to answer them personally too. Yes, the QR codes and the instructions for how to obtain your continuing educations will all be in the slide deck, which again, you will get within a week or so, along with the recording as well. All right. Well, thank you all, and I hope you have a wonderful rest of the day.